here in place of Commissioner Loizon today.
Hi, this is Amanda Beal, Commissioner of the Department of Agriculture, Conservation, and Forestry.
I am Beth Valentine. I'm Director of the Food.
I am Dr. Isaac Benowitz. I'm the State Epidemiologist and Chief Medical Officer at CDC.
Good morning. Nope, good afternoon. Becca Bolus with Maine Public Health Association.
Diane, will you introduce yourself, please?
I'm Diane Rowland. I'm the Dean of the College of Natural Sciences, Forestry, and Agriculture and Director of the Experiment Station at the University of Maine.
Thank you. So our co-chairs are, as you know, both legislators, and it's hectic time across the river. They asked us to proceed without them, having full faith in the work of this committee to assess the work of the health subcommittee, which is the focus of today's meeting. And I wanted to point out that the health subcommittee is a broader mission than the others. They are responsible for strategies that will be shared by both DACF and Maine CDC. Their proposals also include support for non-farmers whose drinking water wells were impacted by land application of biosolids. These strategies also include clinical recommendations that are applicable to anyone with PFAS exposure. This committee did an incredible amount of work over the past 4 months. Bi-weekly meetings. In between, there were subcommittee meetings. A ton of work has gone into developing these recommendations. And with that, I will turn the controls over to the co-chair of the health subcommittee, Dr. Isaac Benowitz.
Great.
Beth, you're going to need to do screen sharing if there's a PowerPoint.
All right. Good afternoon, everyone. So as I mentioned before, I'm Dr. Isaac Benowitz. I'm the State Epidemiologist and Chief Medical Officer at Maine CDC. The health subcommittee was co-chaired by me and Becca Bolus from Maine Public Health Association, who is here with me in the room. Several people in this subgroup, this subcommittee, have extensive clinical and public health experience with PFAS or brought important community perspectives. And I'll also note that we had strong health professional input. Our 9-person group included 5 physicians and 1 nurse, who is also a state senator.
Sorry, we're fighting.
All right, playing with technology. So we developed 8 strategies, which I'll walk through in a moment. These cover blood testing, health monitoring, mental health care, and educational resources, and also propose important programs related to public health oversight, medical treatment, a clinical trial to advance the science around medical treatment, and a biomonitoring study to gain a better understanding of the key ways that PFAS gets into the body in the affected farming communities in Maine. Sorry, I was already there. We propose recommending blood testing for PFAS for all persons exposed to elevated levels of PFAS in water or soil related to farms with land application of biosolids. These people will need to see their doctor, who will order a blood test, and then the blood specimen for that test will be collected in a normal clinical laboratory setting, like any other clinical test. We recommend that the fund support the cost of testing by establishing contracts with private testing laboratories to pay for those costs that are not covered by insurance. These tests can cost over $400 and are not covered by many insurers currently. And there are even larger gaps for people who are uninsured or underinsured. Additionally, there are also costs associated with collecting the blood specimen before it's sent to the testing laboratory. We also propose establishing public health oversight of blood testing in the state. Maine CDC plans to add PFAS blood test results to our list of notifiable conditions, which would require laboratories to report all PFAS blood test results to Maine CDC. Using that information, Maine CDC could then contact the tested individuals to provide them with information about what those blood test results mean for their health and information on how to decrease future exposures to PFAS. Maine CDC would also be able to ask those people to voluntarily share additional information about how they could have been exposed to PFAS through water, soil, and other routes of exposure, which will help Maine CDC improve messaging for the public. Medical monitoring is important to help identify any health conditions resulting from PFAS exposure early on before those conditions worsen. Our clinical recommendations include screenings for elevated cholesterol, thyroid and liver abnormalities, gastrointestinal disorders, and breast, testicular, and kidney cancers, all of which have been linked to PFAS exposure. Many of these health screenings are part of the standard of care that all patients should get at regular checkups. Some of them vary depending on age, and some of our recommendations vary depending on the blood PFAS level in the individual, which is why it's important to get that blood test before starting monitoring. However, I'll note that many of those standard screenings don't actually happen for many people, even though it's recommended. And so the recommendations from our subcommittee and from this group can provide added direction and weight to help ensure that clinicians are performing those screenings in this group of people, where we have even more concern for identifying certain health issues. Much of this medical monitoring can be done in the primary care provider's office and is covered by health insurance. However, for people who lack insurance or whose insurance doesn't cover all of these screenings, the fund should pay for these components of health monitoring, including appropriate follow-up testing when abnormalities are identified. I'm going to take a moment to just briefly walk through what some of these medical monitoring components look like. This is a pretty busy table, and I realize that the text is small, but I just want to provide this as an overview of our recommended medical monitoring. It's based on blood PFAS level and based on age. The core of these recommendations come from the 2022 report from the National Academies of Science, Engineering, and Medicine. Those recommendations have been delivered to the US Agency for Toxic Substances and Disease Registry. And so some changes to our recommendations could occur once ATSDR issues their own recommendations to clinicians across the country. This companion table shows the types of PFAS-linked conditions that clinicians should screen for in exposed people. The middle column shows some of the initial screening tests for these conditions. When a screening test identifies a concern for a particular health condition, further tests, shown in the column on the right, are often needed. For example, if we look at the second to last row, which is liver dysfunction, clinicians would routinely perform liver function tests on people based on their age and based on their blood PFAS level. If abnormalities are identified, follow-up testing could occur involving hepatitis serology and liver ultrasound, which are shown in the column on the right. We would expect that some people who were exposed to PFAS will develop health conditions that have been linked to PFAS exposure, and they'll need medical care for those conditions. We're not able to say that one individual's health condition was caused by PFAS, since these are health conditions that also occur in the general population. And so on an individual level, we don't know whether someone got, for example, a kidney cancer because they were someone in the general population who would have developed that anyhow, or whether it was specifically because of their PFAS exposure. We do know that people do a better job of taking care of their health when the cost of their healthcare is lower. The state should explore ways to provide medical care for health conditions linked to PFAS in these exposed individuals. Some possible mechanisms for doing that include lifetime access to main care, enrolling these individuals in the state employees health plan, or if the Attorney General succeeds in the lawsuit against PFAS manufacturers, some of the settlement money could be allocated to paying for medical care. We also discussed the possibility that there are currently some treatments under investigation that can reduce the PFAS blood level even faster than it will drop over time on its own. None of those treatments are currently among our clinical recommendations for all or some people with elevated blood PFAS levels, but that could change in the next few years. Once some of those treatments are standard of care, the fund should pay for treatment for eligible individuals where that care is not otherwise fully covered by insurance. This would help to reduce the occurrence of health conditions linked to PFAS exposure and could be one of the most meaningful things that this fund does. I noted a moment ago that there are no treatments to reduce blood PFAS level that are currently offered in most clinical settings because none of them have the evidence base that's needed for doctors to see those as normal treatments. But we do know that there are some treatments that can reduce the blood PFAS level, and we simply lack evidence to show that they actually improve health outcomes. And so we actually have an opportunity here to advance the medical science related to treatments that can reduce the blood level of PFAS to see whether or not those actually result in better health outcomes. The PFAS fund could support a clinical trial to help advance the science of PFAS reduction treatments. Such a study would look at a broader group by gender and age than earlier studies. It would enroll participants with much higher body burdens of PFAS compared to earlier studies. And perhaps most importantly, such a study could follow these participants over time for a long enough period to see if the faster reduction in blood PFAS level is actually linked to lower rates of PFAS-linked health conditions. In somewhat medical jargon, doctors talk about whether you're treating a number or actually treating the patient. So right now we know that some of these treatments can reduce the blood PFAS level. What we really need is the evidence base to show that they improve health. I also want to note that designing, launching, and evaluating a clinical study of this type is quite complex and is really outside the expertise of any state agency in Maine. If we were to move in this direction, we would need to contract with a vendor who would design the study and solicit bids and identify the awardee. The launch plus the study would take several years to complete. I also want to talk a little bit about mental health and mental health support. PFAS exposure can lead to stress, anxiety, and other mental health concerns. The PFAS fund should support the mental health needs of farmers, family members, and workers exposed to PFAS. We recommend establishing a state-funded program to expand access to existing mental health resources. In thinking about what this program could encompass, we looked at two existing programs that are worth considering as models. The PFAS Wellness Fund, which is managed by MOFGA, provides funds to pay for a range of stress-reducing supports. The other program we looked at is Cultivemos, which is a regional resource currently funded through the Farm Bill that aims to improve access to behavioral health providers, supporting behavioral health awareness, literacy, access, and outcomes through a service provider network. A state-funded program could follow one or both of these models to provide counseling services and to provide financial support for other stress-reducing practices. Several groups have valuable perspectives on the best forms of mental health support to offer. And as this moves forward, the fund should consult with some of these key stakeholders to identify the priorities and develop the best model. Of course, no system of blood testing, health monitoring, medical treatment, and mental health treatment is really going to accomplish much unless the exposed people know that it exists and healthcare providers know how to guide their patients and know what their patients need. And so as part of these strategies, we plan to support the development of materials to educate the public and clinicians about where PFAS exposures are occurring in the state and what to do about it, both for people exposed on farms related to spreading of biosolids and also more broadly. Some of the key target audiences for these educational resources include farmers and residential well owners, people currently or previously living with water or soil exceeding threshold levels, and clinicians caring for patients with PFAS exposure. These materials will benefit all exposed Mainers and the clinicians caring for them, even more broadly than just those exposed from land application of biosolids. And I also want to talk briefly about a proposed biomonitoring study. We know that people who live and work on PFAS contaminated farms can be exposed to PFAS from their water, from the soil they come in contact with, and through foods. But we actually know very little about how much PFAS found in blood comes from exposure to soil and some of those other routes. A biomonitoring study would help us answer some of these really important questions and would help inform our guidance about how to reduce PFAS exposures going forward. A study would collect blood specimens from individuals who participate to measure their overall PFAS exposure, and it would collect information about those farmers' occupational activities, as well as collecting environmental data on PFAS levels, particularly in soil as well as water. Analyzing those data would vastly improve our understanding of which sources of PFAS on contaminated farms are the major sources of elevated blood PFAS levels in these people. With better information about key sources of exposure, we can develop better intervention strategies to reduce exposures to PFAS in these settings. This slide summarizes the estimated budgets for the strategies that I just presented. Some of these budgets are presented as total numbers and others are presented as annual expenditures. Annual expenditures include things like public health oversight and medical monitoring, and total expenditures are more appropriate for things such as blood testing over a fixed number of years and a biomonitoring study. The estimate presented for the clinical trial is on the lower side and is based on a more limited study concept that only looks at reductions of blood PFAS levels. That number would rise by a few $1 million for a clinical study that actually looks at health outcomes, which would be even more valuable. This concludes my presentation. Becca and I are here and we'd be happy to answer any questions, and we look forward to your comments and discussion. Thank you.
So do we have any questions or comments from committee members?
Oh, I'm sorry, I haven't been to some of these former meetings, so I'm starting from a little bit behind, but it looks like when you talk about the cost per year, you're looking at a 5-year cycle.
Yes.
Okay, thank you.
And our enabling statute didn't really put any time frame, but looking at the overall budget of $60 million, it seems like to do all 24 strategies contained in this draft plan, the money is not going to last more than 5 years.
Can I ask for the longer term studies that you're talking about, what would a reasonable length of time be? I mean, just sort of thinking about how much time we know we have funding for versus what would be the right amount of time to follow a person, you know, to get exposure.
Yeah, so the biomonitoring study would be a more fixed sort of venture that I think we could probably complete in about a 2-year period. But the clinical trial of phlebotomy, conceptualizing it, launching it, watching people over enough time to see their health outcomes, we're probably talking about 5 years.
Okay.
So any other response from committee members?
I would just say,
This
I
is so
it's
funny. This happened last time too.
No, I was gonna say, I mean, clearly you all put a lot of work and thought into this and I really appreciate it. I think it sounds like a very comprehensive set of recommendations based on what resources we have to work with.
Thank you.
Thank you.
I have to say, you know, within our group, you know, we have broad representation, but also several people from Maine CDC. We definitely saw the need to advance how we're able to support the health of everyone exposed to PFAS in the state, not just the group that's exposed through land application. And so pursuing these strategies for that population will also really help advance what we do for a larger group of Mainers.
Yeah, yeah, and I think, you know, the way we've talked about this too in the research subcommittee was that, you know, we're laying out our best thinking right now, and over time, we'll know more, and the path might change, or there might be other things that we need to expand into, but I think this set of recommendations with all of the other ones that we've heard about so far it's a really good foundation. And it'll be interesting to see what kind of public comments we get, and that might also help us to refine some of our thinking.
Yeah, I guess to that end, I just want to make sure I understand. So the funding for all of this really is directly tied to land application sites and information that DEP is finding from its investigation. And I just wanted to clarify that's the extent of it, because there are some other types of locations where there may be some exposures, and so it doesn't apply to everyone across the state, and it won't apply to sites or locations that have other sources of PFAS.
Right, so we did this work based on estimates of the total number of people living and working in proximity to those contaminated sites. Obviously, work is still ongoing in the state to understand just how high the water levels are, and to learn really how many people, have lived and worked in those farming locations. But that is the extent of what these estimates are based on.
Thank you. I just wanted to clarify that for the public that's listening in, because that's an important distinction. But interestingly enough, the information that's obtained from this would still, what's learned will still apply to those others. So it's not in vain.
Right, and it doesn't mean that, the legislature couldn't at some point in time allocate resources and direct these programs to be more widely available. I think it would just be a resource equation at that point in time once they've been stood up.
Right. The portion of the statute regarding healthcare is fairly broad, providing medical care to a person found to have blood levels of PFAS greater than the general population or health effects associated with exposure to PFAS. And also knowing that the genesis of this fund was to assist commercial farmers impacted by land application of biosolids. We sort of put those two together. So the initial proposal is that these health strategies would apply to commercial farmers as well as to private landowners whose drinking water wells were impacted by land application of biosolids, whose water tests above 20 parts per trillion.
I'll also just make a brief comment in terms of sort of the breadth of implementation of these strategies. I think, we see from the subcommittee group, we see a lot of value in making sure that we're improving access to all of this for people who are impacted and affected. Based on some of our early experiences at Maine CDC, I'm concerned that there are a lot of people who have been exposed and could have their health impacted by PFAS who don't know enough yet to be concerned. And so while we tried to make sure that our, budget estimates were high enough, I kind of worry more that, what if you had a strategy and nobody came? I want to make sure that people are actually engaging in things that could positively impact their health.
So I don't know if I'm going to get in trouble for asking this question. I'm sure I will. But so the 20 parts per trillion number, we all know that there may be some changes at the federal level that will affect the state, and that the state may have its own numbers in due time after that. And how does this kind of mesh with that? Or
so that numeric threshold for PFAS contaminated water is really what's driving a lot of the sort of discovery and blood testing. But ultimately, our strategies really focus on the PFAS blood level that someone has. And so what could change over time is the way that we scrutinize different environmental sources and how we think about how people are getting exposed to PFAS. But our strategies based on someone's blood level are not going to change just because we're identifying people in a different way.
Beth, I have a question.
Yes, Dan.
This was great, very detailed. I may have missed it. You are talking about these clinical trials and medical monitoring. Are you putting forward a possible inclusion of following mental health impacts over time?
That's a great question. I think, there's a lot to learn from here for sure. Broadly, in thinking about medical monitoring and medical treatment and mental health support, these are really things that we're conceptualizing as services to be delivered, not as a population to be studied. The concepts around a biomonitoring study and also around a clinical trial of phlebotomy are really separate activities. Obviously, it's an overlapping population, but I think the two things that I would say about studying the impacts of these programs are, one, it would take additional money and resources to collect that information, which is not something that we had laid out. And the second is that while I would love to learn from it, I also sometimes worry about things characterized, whether you call them research or implementation science, I worry about it creating a hurdle that people would be averse to seeking assistance if they, were not comfortable with their information being shared.
Thank you.
If there's nothing else, I would like to turn our conversation to the public hearing, which is scheduled for June 12th. Let me just share my screen again. So this first slide is really, whoops, it's not showing it, sorry. This first slide is the overall budget for each of the 4 different categories. Direct financial support to commercial farmers being the greatest, then land purchases, followed by research and health. As noted at the beginning, our total present budget is $60 million. So we have some trimming to do. This has always been designed to be an iterative process. The budget estimates are based on data where we have it, and assumptions based on our best guesses. Over time, as different people take advantage of the different strategies, we'll have a better sense of, do we actually need as much money in direct financial support? Do we need more for land purchases? How much maintenance is any particular property going to require? That's going to vary considerably if it's fields versus a dairy farm with all of the upkeep to maintain those buildings. Are we going to hold on to this land for a long time? Are we going to sell it? How many people are going to take advantage of the blood testing? Of those, how many are going to test above sort of the average population and therefore be advised to have sort of stepped up medical monitoring? So even though I think 20 million over budget is a lot, I really don't think, I think this is a good starting point that we can refine as we move along. So with that, next steps, public hearing. And that will be the opportunity for the public to comment on this draft plan, which is presently available on the department's website. And we'll be doing press releases and getting the word out far and wide ahead of June 12th. Sort of logistics for the day of the hearing, the committee members will all be sitting at a table facing the audience. We'll ask any camera crews that may be there to be at the back of the room. At our last public hearing in January, it was off-putting to some people to have the TV cameras at the front of the room. It felt a little intimidating. So we'll make sure that people are comfortable. It's hard to judge how many people will show up. I think if there is a large crowd, we ought to consider limiting comments to 3 minutes like the legislature does. I want to note that there is going to be an online option for people to comment, and I've just started developing the, is this bar showing up? No, it's just for, it's just for you. Just for you. So I've just started drafting this, but right now, I'm asking folks to rank each strategy as low, medium, or high. They can comment on each strategy, and then I have some open-ended questions. How can the fund best support farmers impacted by PFAS contamination? Do you have recommendations for uses of the fund that are presently not included? And is there any health-related questions specifically that you would like the fund to address? So I would like to hear from the committee members. Are there other questions we ought to be asking on this online form?
I have a question about the ranking.
Mm-hmm.
How do you think we're going to use those data once we get them? And is the committee going to do the same exercise?
I imagine when the committee reconvenes after the public hearing, it may be necessary to prioritize within each of the different headings. So I guess I hadn't decided yet whether we would explicitly ask the committee to also rank, but I think having that input from the public will sort of help get a feel for.
Yeah, I agree. I've been thinking a lot about how we translate all this information into action, making decisions. So I like that idea.
And I guess sort of a variation on that question is, do we just have 3 options, low, medium, or high, or do we have like a greater gradation? In terms of interpreting the results, I think having low, medium, high simplifies it. But is there value in having like 5 options?
If it would help to give some guidance about what those ranks might mean, whether you're asking people to deprioritize versus drop certain strategies. And that might help people understand how to use those scores.
Right.
Yeah, similarly, like we send out a policy survey to our members and we ask them to rank, and everybody puts everything as high. So we force them to order them, and that might be something for us to consider within each of the subcommittees, or in some relational, force them to rank the priorities. I don't know if it's for all of them or if it's within like land or research or health or something like that, but that might also help us, because I hadn't thought of that when I saw the form this morning. I thought it looked great, and then your question made me think like, yeah, if everyone thinks high, what do we do then? Yeah.
I'll play devil's advocate. to
Sure,
that. I think that's really valuable, but suppose I look at 3 strategies and I want to indicate that we should keep all of them, then just providing ranks wouldn't let me do that. And so the other way to do it would be to ask people to score each one on a 3-point scale or a 5-point scale. And then depending on what those results look like, you figure out how you want to interpret it. It might lend itself to, looking at people's priorities or rankings, or it might just provide support for keeping all the strategies.
You still could end up with like all 3s.
Oh yeah, no,
Okay.
I've fallen into that. I've fallen into that myself. Yeah. And I've put out other things where I asked people to rank things as like, high, medium, low, and I got like one person scored things as like high plus plus, high plus 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 plus.
But I guess even if people do rank, highs across the board,
That tells
Still,
you
that's
something.
telling.
It still,
Yeah.
still tells you something, absolutely.
I'm not sure,
Yep.
I'm not sure what you do if people
But then
rank
we
everything
can-
low.
Yeah.
I was gonna ask about your open-ended questions. The first one, how can the fund best support farmers impacted by PFAS contamination? And it sounds like the proposal is to include beyond just farmers impacted by land application, but also some residences. And so I wonder if you wanted to reword that so that it includes farmers and those impacted by land application.
Good point. I guess, the emphasis of 3/4 of these strategies are on the commercial farmers. But with regards to health, you're right, it does extend to residents, non-farmer residents.
I'm wondering about that question because aren't the strategies we're proposing, isn't that what we've determined? And they're going to be commenting on the strategies. I mean, that is what we're putting forth as
I had the exact same.
how to best support farmers. I think we've gone through a process and putting that question out there just opens the whole thing right back up again in a way that I'm not sure would be totally helpful. I think we want to keep people focused on what's in front of them.
I think the first open-ended question could still be construed within the strategies, but I'm a little more concerned about the second open-ended question, that it opens the door to things that are sort of explicitly outside of the strategies. I'm not sure what the committee will do if you get comments about things that are not, covered by the existing strategies.
Yeah, and I guess the flip side, I think the subcommittees have put so much work in and have tried to be very thorough. And part of our exercise in developing these was thinking about who's being left out and is there something the fund can do to not exclude people. But I guess I would hate to, even with all the good effort that's gone in, to miss something.
I guess I'm not too worried about it. I mean, it will be information and unless there's something that jumps out at us. I mean, we know we have limited resources and we've kind of gone at this from that perspective. I'm sure there are other things that would be helpful, but we can't do everything. So, I mean, it's helpful to know what other people think. It doesn't mean we're gonna have to change everything we're doing. Or it might compel us to change something, I don't know.
Speaking from the perspective of one of the subcommittees, it's really helpful if each comment that we get from a member of the public is tagged as linked to a specific strategy or is general and not pertaining to a single strategy.
Yeah.
And then I think that will help us interpret the information that we get from the public.
That's a great point. Yeah, we'll have to do it for responses anyway. Right.
So strike the first question.
Well, I was just thinking about, does it make sense to include the strategies there? Are there other, direct them to the strategies?
Yeah, so I should have explained, the way the form is set up now is, there'll be an introductory paragraph and then a list of all 23, 24 strategies. And people will be able to, I wonder how many people are going to go through all of them. But there'll be a list, and if someone is just really interested in land, they can go to those, 4 land strategies and rank high, medium, low, and comment on each one. So there'll be a little summary statement of the strategy, and then a link to, to this document, as soon as they want to read the details. And then, a box to insert comments on strategy 2B. So we'll have all of that. I guess, so my thought with the open-ended questions was for the people that aren't going to slog through the whole survey, but sort of have broad comments they want to make. I wanted there to be an opportunity for that.
See that.
But if it's not tied to a specific strategy, I can see that being less useful than a comment, to a specific recommendation.
Almost want a statement in there that acknowledges that while we value comments about anything pertaining to this subject, comments that are specific to particular strategies are going to be easier to incorporate.
Yeah.
Yeah. I can put that in the intro section.
The other thing that's on my mind, and I'll just offer this up as a general comment, is it's probably not as much related to public comments and more related to how the committee thinks about funding. Just speaking from the perspective of the health subcommittee, there are some things in there that, if you said you can't have $800,000 for blood testing, but you can have 300,000. There are a lot of ways to implement that. You could offer a smaller portion of money to each person, or you could spend until you run out. But there are other strategies like a clinical trial where you either have $4 or $5 million or you don't. So I think it would be helpful to consider which things can be funded sort of thumbs up, thumbs down, and which things could be sort of funded until money runs out, or sort of how the funds will get used.
Yeah, good point. And then this last question, would you like the PFAS fund to support research to investigate any specific health-related questions? That is the result of an email exchange among the health subcommittee yesterday. So I guess I'm asking Isaac and Becca if that, should we have a specific health-related question? And if so, is this the right question?
So 2 or 3 of the health subcommittee's strategies essentially address research, right? The clinical trial, the biomonitoring study, and then to a lesser extent, public health oversight. While it's a public health program, it's sort of research related in that it improves our understanding. So is the question that you're posing to the public whether or not the fund's dollars should be spent on some of the research as outlined, or whether there are aspects of those strategies that they would change, or whether there are areas of research that they would want to see the fund support that are not already encompassed in the strategies?
I guess the latter.
So the question is really, are there other research activities?
Other than what's been proposed.
Yeah.
Are there research questions outside of the proposed strategies that the fund should consider?
Yeah, I like that.
And I think that's helpful for us to know. I mean, that could even inform our education efforts, even if we don't end up designing a study, like just knowing that people are wondering about this area that could impact other things.
And is it just health, or I don't know if Diane wants to weigh in on this, but I wonder if we could craft that question so that it's about either health-related studies or research of other types.
Yeah, I think that would be really helpful to understand if we've got a set of topics in the recommendations in the report, but it's not necessarily exhaustive. So I think that would be really helpful to gather that information.
Okay.
I think you could add that other than the strategies provided on the first question too. Just to, do you have other ideas? Just to clarify.
Well, if we make that change, then it's more or less the same as the second question. So maybe I just collapse the 2 of those. What are we missing?
Yeah, I think that works.
And maybe the same way that you had a space to comment on each strategy with a link to the strategy, the open question about what we're missing might have a link to our statutory authority. Because really, it's going to be very hard to act on any suggestions that fall outside of the
Great idea.
the scope.
Yep. Good thinking. Okay. Thank you, that's all really useful. So yeah, this is just where we are. We're closing in on the end of the planning phase. After the public hearings, the subcommittees will meet again to assess the public comments and to put together their best recommendations to the advisory committee, which then meets July 10. I guess once we have the input from the public hearing, we can assess whether it's likely that we can finalize this plan in a single meeting or if we may need another one. But hopefully at some point in July, the plan will be finalized and we can start moving into the implementation phase. Any comments? Okay, thank you, everyone.
Thank you.